everyone, and I am your host, Chris Marchack, and welcome to our Clinical Chats, episode 49, where we hope to enlighten, entertain, and educate you on all topics in the field of dentistry. Clinical Chats has been on a little hiatus, but we are back. Please be aware that we are unable to see or hear you, but we encourage your participation and are happy to address any questions you may have. Simply click on the Q&A button located on the right-hand side of your screen. We will make every effort to answer them during the webinar. Rather than having a designated question and answer time, we aim to integrate your questions and comments throughout our session to maintain an engaging and interactive experience. Please feel free to submit your questions whenever they arise. The CE credit will be sent via email to the address that you provided, and it will be provided within the next 48 hours. And this session will be accessible on demand in the next coming days. Now, on with our program. For those of you who have joined us before, you will all know my dear friend and co-host, Dr. Frank Vidjak, prosthodontist in Beverly Hills. Hey, Frank, it is great to see you back on Clinical Chats.
It's fantastic. It's it's one of those things. You get so much in wanting to do this, and it's even better when we get back to it. So I'm looking forward to it.
Hey, and Frank, this episode, we have our dear friend, Dr. Brian Goodacre, prosthodontist in Upland, California. He's also the Director of Clinical Technologies for Noble Biocare. Brian, great to see you.
Thank you for having me. It's always good to be back, and it's always good to spend time with you guys and of course, the audience. So thanks for having me.
Now, you're not in your office. Where are you?
I'm in Oklahoma, Tulsa, Oklahoma. So the joys of the internet. We can be anywhere, right?
Fantastic. Well, we're great to see you. Great to have you both on. Hey, both of you, for this episode, I would like to discuss a really intriguing case of this patient that came in to see me. And this patient, he came to visit me in my practice. This patient has a significant internal root resorption. Tooth number 8, the maxillary right central incisor. Numerous professionals in clinic have recommended that the extraction of the tooth, and she's considering an implant as a replacement. However, it is crucial to note that this patient has specific concerns relating her high smile line and the presence of a couple diastemas, which includes a 1 or 2 millimeter central diastema, as well as a larger diastema between teeth 7 and 8. It is important to carefully consider the treatment plan because of this patient. Now, when should we proceed with extracting the affected tooth? When would we be appropriate time to place in the implant? Additionally, what are main concerns in this case, as there seem to be several red flags despite being a single implant procedure? But before we start this chat, guys, let's launch our initial poll. How would you treat this patient? 1, would you extract the tooth immediately and have orthodontics? 2, would you extract with immediate implant placement, then orthodontics? 3, extract and graft with future implant placement? Or 4, forget the implant. Let's just do a 3-unit bridge. But as we're waiting for that poll, Brian and Frank, is it just me, or have you been seeing an increase in patients having internal root resorption. I just remember,
I'll go ahead. Go ahead. Go.
Either internal or external root resorption. I've just been seeing a large change, because when I first saw in my first years, I would see one patient a year at most. Now I'm seeing like multiple patients, 2 patients a month I've seen before with internal or external root resorption. What are you guys seeing?
I'm
Frank?
Yeah. What can you hear me?
I can.
Yep.
Okay. The incidence rate, and I don't think it's just because we're better at looking at it, and looking for it. And I'm seeing it in all age groups. Just yesterday, I saw a 15-year-old with 2 teeth affected and no history of orthodontics or any kind of trauma. Just happens to be affected. And it'll go all the way up to people in their 80s. I'll see cervical resorption, root resorption on these patients. I don't know. Obviously, I'm not smart enough to know exactly what the etiology is, but it definitely seems like more of a normal event. And like you said, I'll see 2 to 3 patients a month.
Yeah, it's really been a big change. Big change. And here's our winning poll of extract, graft with future implant placement. Isn't that interesting? 57%. 16% says let's do the orthodontics first, and 21% says to do the extraction, implant placement, then the orthodontics, and a small percentage of 6% said forget the implant, let's just do a 3-unit bridge. Brian, any thoughts about the resorptions that we've been seeing?
Yeah, I mean, I've been seeing even external root resorption too, which has been interesting rather than just internal. And so it has been interesting. I can't say that can't say I've seen a huge change in the number, but I see more. I just see quite a few of them, so I don't have any reference to say that it's more than before. I've definitely seen more than I probably thought I would. Just because normally I'm thinking, okay, that is in my head, I think it's going to be caused by some type of trauma or something that's going to do this. But like you're saying, some of these external root resorption that I've seen, no trauma noted. It's just something you end up finding, and it's a surprise. So yeah, but I did think we definitely see more.
In fact, just a patient that came in to see me last week, tooth number 3, the first molar. 1 year ago, I placed a crown on the tooth. Everything was fine. He's seen on a 3-month recare constantly. Everything is okay. In the last 3 months, we saw a huge internal or external root resorption, an external root resorption that has progressed so aggressively that he has to lose the tooth within 3 months. I have never seen it move so fast like that. And we have records of it showing all the periapical radiographs. It's crazy. We've had a few comments here. Go ahead, Frank.
No, go ahead. No, I was just going to say that's why I think this topic is great for future chats, because the same thing. I mean, I had a mid-30s young lady who, every 6 months, and then had a lapse for about 1.5 years. Saw her, and all of a sudden, mesial and number 18, so resorbed within that period of time. Never a history for anything, and then loses the tooth. It was impressive.
Wow.
Frank, maybe we need to have Dr. Yakiman come on the show, and she's been the expert.
You're kidding? She would love it, and I think probably because of being associated with her, we just see such a larger number of these patients, because that's her passion is trying to treat these patients, and they come from everywhere. So our view is a little skewed.
So we are getting a few comments. We're getting a few comments in about the about our patient here and the poll of everything. One thing that I really didn't mention at the very beginning, and it's really important, is that the patient never had diastemas before, progressively getting worse, and she does want to correct it. I think that's a really important point right there. There is a correction that she does want to make with that. Another comment here, whoever this statement is that there was a big change. Absolutely noticed a dramatic increase in their patient pool, especially in the last couple of years, and so forth. So, Brian, what are your initial thoughts with this patient? What are your concerns? High smile line, what should we do?
Yeah, there's absolutely the high smile line becomes the number one, right? Because you're dealing with a front tooth. You look at the adjacent teeth. When I look at those, they're untouched basically, except for maybe a little chip on the mesial of incisal edge of number 9. But otherwise, it looks like they're virtually untouched. So you really understanding. Okay, now you're thinking not only is it high smile line, so now all of a sudden soft tissue changes. We got to be very cautious of that. But you're also thinking the final restoration. I'm assuming we can all agree that one of the hardest things to do is match a single central incisor, especially when the teeth on either side are natural, because they're likely going to have some unique characteristics. So it's just more of a challenge from that perspective. So I think when we look at just that, sure, the high smile line is a big one. I think also I'm personally leaning towards, okay, once that tooth comes out, obviously that's going to be probably in some senses could be difficult to take out because of how large the resorption is. So it's likely to break. And so you just start thinking that's going to be a fun challenge. And then I lean towards, if we're going to put an implant, which is what I would lean towards, that becomes, you're going back to the discussion of high smile line. Do we need to do any tissue considerations of tissue grafting or anything? That's the initial thought. Again, that's a lot, but.
Frank, what are your thoughts? What's your initial concerns? Anything different than what Brian has suggested?
Well, yeah. Well, not really. It's Brian covered it really well. I mean, one risk factor is expectations. And the one thing I noticed is, the high smile line, brings out potentially high complicating factors to go with it, high demands.
Yes,
on outcome, the high expectations of it. But I noticed the nubs, the composite on the teeth. Did this patient already undergo ortho treatment? Did she stop and the teeth relapsed? What, she didn't use her retainer? What happened?
Yeah. So I kind of let the cat out of the bag with those photographs, didn't I? She was definitely concerned about the diastema. My concern is about ideal implant placement, because the anterior segments do tend to be flaring anteriorly. And with the high smile line was my biggest issue and biggest concern. So we did have an orthodontic consult first, as well as a periodontal consult to see, when we should take out this tooth. How do we need to manage orthodontics? And when is implant placement?
Well,
those are my thoughts.
Okay. So my question is, clinically, did you see any tongue habit with this patient?
No.
Any kind of, no?
Not
Posterior support is fine. There's
posterior
support. I see it
fact,
here. It's there.
In fact, we can actually look at the panoramic radiograph there. Fully dentate.
Yeah.
It was a tooth that was traumatized early in age, root canal treatment, root canal therapy, and then as well as restoration placed afterwards.
Okay, so
and this may have been the second crown that was placed.
Okay, well, I still will say that there must be a factor, and it's hard to know. But teeth typically don't flare without some motivation. This patient obviously seems to have good musculature around the lip and all that. So it's like, okay, then something internal must be pushing them out. But that being said, Okay, forget where it's coming from. The space is there.
Yes.
And my preference, only because this is an invasive process. If I see, when you look at that radiograph, this tooth had endodontic treatment. That in and of itself stops internal resorption. Okay, that's it.
Yes.
It's done.
Yes.
That much we know. But looking carefully at it, there seems to be an external portal where I'm pretty confident that cervical resorption, on the distal, found its way
Yes.
in. And so
Yeah.
that
You're
tooth
talking
is
about
just,
this area right here.
yeah, exactly, right in there. So it found its way in. And that's why, look, you see the endodontic fill there is just floating.
Yes.
I mean, once you take that vital tissue out, that's the one kind of resorption that right now we're very confident. You take that vital tissue out, those active cells resorbing internally, you get them out, you've controlled it. Okay, it's done. The process is done. But what you don't know is the effect, because there can be, and this is what's great about hanging around somebody who really delves into this topic. There's communication of cells through methodologies that are still being studied. There's no real firm understanding what their cellular system is. You kind of play a pun on words there. Like our phones, right? We're able to connect with people very easily. And these cells communicate. And there's oftentimes this communication from internal to external and vice versa. And the triggering effect, we just don't know. So what exactly happened on the distal? Because I'm thinking, how else could the tissue get in?
Yes.
If it got treated and that obturation is any example of what the canal space or shape was before, it had to come from the outside in. Okay, so my thought of keeping this tooth and doing orthodontics around it, I'm not comfortable with that. This is an active process, which orthodontic movement in and of itself is controlled trauma, right? And we don't know when we do orthodontic treatment, why do you think there's, at least every 6 months, an orthodontist has imaging made so they can check on the roots of the teeth, because they want to know, are the roots shortening through resorption? Okay. Well, why would I want to move teeth around an area that already has a resorptive process? To me, and there's no real gain in it. And that's where I'd like to know what a CT scan shows, a CBCT, because it's very possible that labial bone's gone already.
Yeah.
Okay. So I don't know what a lateral view would be like of this zone, because this might be one of those that the patient really has to get their act together and tell you exactly what they want. Because if they want ideal aesthetics, even if it was a 3-unit fixed dental prosthesis, even if it was, yeah, you can manipulate contours more easily with a 3-unit, absolutely. But you're going to get into the crowns, and that takes care of the single central problem, right? Matching it. But with that fixed restoration, you can be creative, with what you do. Whereas with the implant, no. And I was thinking about this a lot. I was trying to think, where's the facial midline relative to the dental midline? You can't move implants, correct? So if the patient can't make up their mind, do you decide? And listen, this is where I love chatting with you guys, because one idea is, do you put the implant where the ideal location would be? And this is where digital is great, right? You can really study it.
Yes.
And then worry about maybe composite resin to close diastemas, or recontour a little bit for the maybe in the future, and all that stuff. But in the meantime, if they want to do orthodontics, Well, now you have another real interesting dilemma, right? How do you manage that missing tooth right in the front, and
Yep.
all the if issues that might come with the bone deficiency when that tooth is removed?
So we've had many questions here of this topic because that seems very interesting. People are intrigued about it. They're finding in their practice, they're seeing many areas of internal and external root resorption just by what you've been saying and your work with Dr. Yakuman and with these types of resorptive cases. This doctor, and excuse me, they're the name of this doctor is Dr. Smolyansky. He says his son or her son is a power lifter, and they've noticed that there's internal root resorption. How do you save the tooth, Frank? What's your suggestion for that
If
doctor?
if if you see, and again, just to be definitive, because it may look like internal root resorption from a typical two-dimensional image. You really don't want to get faked out. Yeah, you can do lateral imaging, so you can, like we used to do before CT scans, mesial,
Sure.
distal, ortho. And if you can know either through tomography or traditional 2D imaging, you can verify that it's strictly internal. There's no external component. You need to devitalize the tooth, because it will not go away on its own.
Root canal therapy, then.
Mm-hmm.
Brian, there's a question for you. What if there's a large palatal defect that is at the level of the resorption? Would you still consider immediate placement?
It would all depend on how much it is, and what you think the cause is from. Because one of those concepts of if you want to put in an implant immediately is, well, one, how much bone do you have apical to stabilize an implant, but also, is there an active infection going on? Because that would be a potential concern, right? If you have an active infection, you're then going to put an implant in there. So it would really depend on what's going on in that. One, how big is it, and also what's likely the cause, and do you think you can remove the source of that at the time you take a tooth out or not? And I think that's a big question, and that's why I think in this example, like you were saying, Frank, I'd love to see a CT of it to really know, because I bet it looks a lot worse than we think when you see it on a CT. It looks bad on the PA, but I can only imagine on the CT.
Frank, here's a great question, because one of the things that you're describing is, let's get the tooth out. And what type of interim restoration, if it's an implant, because she's coming in asking for an implant, what type of interim restoration is being planned, especially considering that she is concerned with aesthetics? Dr. Applebaum has asked.
I mean, that's a good one, because it brings in the whole, because of her smile line, the amount of display, it doesn't make it real clear cut. Why? Because if we look at the occluded view, there's a moderate vertical overlap. If I were to, I know this sounds, maybe too traditional, but yeah, there are the overlays, the Essex type of situations. But if the patient's going through ortho treatment, that's not going to be an option. Okay.
Yeah.
The whole question will come up, how likely is it going to be to treat a patient? Yes, you can do with aligners. You can fill in a tooth, right? Because you just do like a Essex. You can do that with Invisalign. So
And
aesthetically,
also, patient compliance is really good when you do that too, because they're always going to wear it.
It's like, hey, listen, their teeth are going to move great. Let me tell you, they're going to come in for their next set of aligners right on
every time.
Okay, so I don't see that really as a major issue. I think, if anything, like you just said, Brian, I think it's a motivating factor. because they want to get that over and done with. But already I think you got an idea. I'm leaning toward the implant restoration. And it's just the way I've been wired. I've been doing this for a while. Okay, great. We don't know what kind of facial form, okay, what skeletal type of individual we're really dealing with. You can kind of guess by the occlusion, but that doesn't always help you with whether they're brachycephalic, dolichocephalic. With continued facial growth, because obviously we have to think about that, right? Brian, notice first thing, high smile line. Well, if it's a low smile line, who cares if the incisal edge over the next 15 years changes a little? But if that soft tissue margin starts looking like it's taking the elevator up, it begins to be a bit of a concern. So obviously having a good handle on potential growth pattern and explaining this to the patient. Because the one thing that we lose track of, we talk about this growth and the complications that come with it. But what's been a real great area of progress, and I've always said this, Chris, you've always heard it in the past. When it comes to implant placement, you want to make sure that pencil on the buccal or labial is long enough so that if changes are going to happen, they're not going to be as obvious, right?
Yeah.
So if you're in this area and it's a thin biotype and you are not sure of getting that 2 millimeter thickness there, you go on the thin side, your nightmare has just begun. Okay, so look at the placement's critical, but let's look at bridges. Okay, what's the typical lifespan of a bridge? Okay, so we know that technically it's going to be, in theory, less than what potentially could be the lifespan of an implant restoration. But yeah, everything has its complications. So then what does that mean? A fixed restoration on 2 teeth has the potential of needing to be redone, right? It saves a lot of things, and that's why we have to consider everything carefully and try to understand the patient, what their motivation is. But again, I like not to touch teeth. If I can leave those 2 other teeth alone, it'd be great. But position to me is everything. Those teeth have to be aligned.
Yeah.
Ryan, there's a question specifically to you from Dr. Joseph Kim. Would root resorption, internal or external, be on your no-go list for partial extraction therapy? Maybe you can explain partial extraction therapy first and then answer your response to that.
Yeah. So, I mean, the idea with partial extraction therapy would be to keep some remaining portion of the root to help maintain the gingival architecture by maintaining the buccal bone and everything else. And I think that's something that, again, that can be a risk factor, right? Because you don't know if it's stopped. So my biggest concern when I look at this patient specifically, I'd be concerned that if you left any piece of it, the root resorption would continue. So I think in this case, I would be very concerned. But I think maybe there's other scenarios where maybe it's not. It probably would depend on, like, let's say the root resorption, internal or external, was on one side of the tooth and you were going to basically focus on the opposite side. So if it was on the palate, kind of like, like we were talking about, if you had palatal root resorption, let's say, and you want to keep the buccal portion of it, or the facial portion, then maybe you could do that, because likely in removing part of the tooth, you would remove a good portion of that. But I think personally, there's a lot we don't know about resorption, right? So I think that's the concern, is we don't know if we're actually effectively going to remove all of that, or if that would come back and bite you later on. So I think it's a great question. I think if you look at the PA for this patient, I don't know there's a lot left that you could keep. Again, the CT would tell you more, but I think it would be a challenge. Yeah.
Brian, there's a newly developed implant in the last couple of years with Nobel Biocare, the N1 implant. Is this a ideal situation for the patient? Or why would we even consider, or maybe you could tell us a little bit about the implant, because one of the developers we've had on the show before, Frank, and that's Dr. Jill Elms, and she was part of the development of the implant. Brian, maybe you could tell us, is this a considerable situation or thoughts?
Yeah. So,
what are your thoughts?
Yeah, I mean, I think obviously whenever you think of an immediate implant, you're looking for something that's going to be a little more on the aggressive side so you can ensure your primary stability, because you know that with an immediate implant, you're engaging only that apical bone. You're not getting much retention or any stability, from the extraction socket itself, or very little at all. So, anything that helps promote that immediate stability is critical, and N1 does that. I think it has a really unique couple factors that I like for it, and I do use it for immediate implants. But of course, one of them is how it shapes the bone. So there's this instrument called the OsseoShaper, and how it creates the osteotomy. Does it under slow? It's a very slow RPMs, so you're not overheating bone. And so there's a lot of research that Jill Helms did specifically in her team that looked at, from a biologic perspective, how that maintains more bone because you don't have that trauma that initially happens around the implant. So from a perspective on a biologic component, I think it really is a great option. It's aggressive enough to be stable, no issues there. But a part that I like is the shape of the implant. So if you haven't seen the shape, look at the connection. It's a tri-oval shape. And what's nice with that is we'd like to put the flat towards the buccal, so it gives you a little more space so you can graft more. So as changes occur, again, this assumes you have the right depth, vertical and horizontal implant position. You have plenty of bone there to stabilize it. So I use it quite a bit. I also like that it uses an angle correction screw, so I can make a provisional that even though the long axis of the implant likely will come through the incisal edge, I can still have the screw axis opening lingual to that. And so that's another benefit as well. Again, more than that, but it definitely could be an option. So
you bring up a good point, and Frank, you have mentioned this before and talk about it in some of your lectures. In fact, we've even talked about writing papers, because where do you place that implant? In a not just buccal lingually, but also in a gingival apical position. You have some theories and even a formula. Can you explain a little bit more about that?
It's amazing as time goes by. You think you have a really good idea, and I still think it's a good tool because we get caught in a scenario where teeth are of varying widths. Okay.
Yes.
And both, buccal lingually, mesial distally. Yet our platforms are fairly narrow, especially when you consider, a molar tooth. When we move anteriorly, like in this central incisor position, your standard diameter works pretty well. I start sweating a bit if somebody tells me they want to give me a 5 millimeter platform. Okay. And I've seen some where somebody thought, okay, let's platform switch a 6 millimeter. And I'm going, how in the heck they didn't thread, the adjacent teeth? I mean, you see all kinds of things. All right. I guess because it must have been a tooth like this with a big defect. They wanted to engage as much as they could. Okay. But in the anterior, we always hear this rule of thumb, 3 millimeters, apical to the gingival crest. Okay. Well, that's where in the anterior you can deal with that, but I'll look at a scan. And this is where it's really great in this digital world, where you can study a scenario, because yes, you have to be concerned about the adjacent bone levels. Right? We have adjacent teeth here. So about the high smile line, if you maintain that interproximal bone, I think we're a little less concerned about losing that papilla. Yep. Having said that, there's nothing worse than not having enough running room.
Yeah.
And I don't know about you guys.
Yeah.
Have you ever seen soft tissue thin out on you when you do your initial surgeries and all that, and everything looks nominal, and then all of a sudden there's like a millimeter less?
Yeah.
Now, posteriorly, that's not good, right? Because we're trying to widen so much. And I don't want, I mean, that's a whole nother chat. Like, how much can you cover soft tissue? What constitutes, access for cleaning? But in the anterior, the worst that can happen really is we don't have enough for that gradual widening.
Transition.
But there's gonna be arguments like, how important is that if the patient can access and clean? But I think it's agreeable that soft tissue has its form because of the root below it. Correct?
Yeah.
Because the implant itself is a prosthetic root within the osseous structure. And we're talking bone level here. Okay, so bone level implant.
Yeah.
But that's not the entire root, right? We're missing a few millimeters of that root, the one that transitions through the soft tissue. Well, why would I want to make that form any less than what was there before?
Yeah.
Right? Because if I'm trying to match the adjacent central, you're really, as a restorative dentist, really making your life hard if that, in this case, it's a maxillary implant. If that implant is in place superiorly enough to give you that running room.
Yeah.
Okay, and that's where digital's great, because you can really study that. Okay, you can really nail that down.
Yeah.
Because you can do the whole prototyping within that software.
Right? Mirror the two things to it. Exactly.
Mm-hmm.
Yeah.
Yep. Uh-huh.
So, but Frank, when is it too far, too deep to create problems? So there's a balance between the worst scenario is that it's too coronal and too high in the tissue because you can't make those changes. But when is it too far below the gingival crest? And is that a problem? So ideally, we are saying numbers of 3-4 millimeters, but what happens if it's 5 or 6? You have more room.
Well, I'll just give you this because I haven't run across that to be so abnormally deep to see what happens. But I do have patients that have, interestingly enough, I have a small group of them that have ankylosed molars. Typically, for me, in this practice, they're maxillary. And they've come to me with these restorations already, like giant Emax onlays. Yeah. And the bone level from adjacent tooth to this molar, it's like going to Kathmandu. Okay, when you look at that slope, I mean, it's huge. Yes. And yet those teeth, they come in for management, and the tooth, because you're talking a tooth. Okay, granted, it's not an implant, but they are manageable. Yes, to me, an implant is a little greater risk because it's not a tooth. Directly from that soft tissue goes directly to the bone. There's no attachment. So yes, I'm comparing apples with oranges. But the question you're bringing up, though, is what's the alternative? And that's why in this case, Brian, like you said, where would you, if you saw the scan and you looked at that morphology of the remaining bone, the best you could visualize, what kind of defect do you feel comfortable with to be able to say, because listen, in private practice, like we always said this, Chris, how much margin of error do we get in private practice? It's like this. Okay. We were an academic, so we know the margin of error goes beyond the screen. Okay. Patients are very understanding if something doesn't work quite right in the academic world. But in private practice, the expectations are extremely high. So, it's so, because this is where I guess clinical judgment comes in, and we always like to make this black and white. But if you saw a scan, I mean, how much proximity to the implant Okay, we can say laterally,
Yeah.
but what do you think from a vertical standpoint? Even though interproximally it looks favorable, right? On this
Yeah.
on
Yeah.
that PA, it looks good.
Yes. Yes.
Yeah. It does.
Where
Yes.
where would you just say, I'm drawing the line here? This has to be grafted. It's delayed. We have to just let this area be augmented first, and secondarily place the implant.
Yeah.
So
For me, it's
where
yeah. Yeah, where do you draw that line? It's a great point. For me, what I look for is I'm looking at how much apical bone is there to stabilize an implant. If there's not enough to stabilize, and I like at least 5 to 6 millimeters is kind of the range I look for. I know some people say less than that, but I like to have, 5 to 6 is not much. It really isn't if you think about it, but that's what at least I need. And I've been able to achieve in at least 5 to 6 good stability. And so if I can't get that, then you have to look at some other options. And, I have to say, a lot of that kind of, whether opinion or different things we learn, it all comes from people I learned from, right? So I lucked out that I got to learn a lot from Joseph Kahn in residency. And again, he's a good friend now. It's one of those, fun parts of the people we learn from. And, in residency, one of the things we got to do a lot of is assist him. And he would, again, then to cover us with surgery if we're doing it. And, the thing with that is you get to see some of the stuff that he's able to do, which, terrifies me, but you see it. And then that builds like, wow, it is possible. But again, I'm not saying I could do it to his level. So, some of the things that he's done that's been really fascinating is he has a tooth that he knows is going to come out, but he does not have the apical stability he needs. Now, again, this is going to the far extreme, but they'll actually do an apico, take off a good portion of the root, graft that ahead of time, let it heal, and then take a tooth out and put an implant in, because that gives you now that bone to stabilize it if he feels he could keep the tooth for 4 months while the bone's healing. So kind of an interesting idea, but sometimes you do that when it's a front tooth, and they can do the apico in a way that they don't disrupt the gingiva, and they can do that, remove the half of the apex of a root, graft it, and come back. So there are ways that even if you don't have the bone, you could come back. But again, that's going to a far extreme. And like you said, that's probably getting to the risky phase, because now you have half of the tooth that has root resorption. Is that going to be able to last? So, I think that's kind of another side that's kind of tricky. But for me, if you can't get the stability, then you're going to have to graft and come back. And I think also if you have an active infection, that's where you have to decide, like, it's probably better clean things out, graft, and then come back and put the implant. But again, those are those different kind of two schools of thought, I think, when it comes to that.
Talking about apical stability, Brian, there's a question for you here. What's the difference between choosing an active Nobel implant rather than choosing an N1, knowing the active has the threads to engage the apical bone? And this is a question from Dr. Hesham.
Oh, how's it going? No, it's good.
That's a very good question.
Yeah. So, when you think about it, at the end of the day, if you look at two pictures of this implant side by side, they look very similar, in all honesty. Mm-hmm. They do, but there is some significant differences. And primarily, one is, like we mentioned a little bit before, how you create the osteotomy. So you are condensing some bone laterally when you use the OsseoShaper for N1. So that does help you get some stability. But the other part, the biggest difference, honestly, is the apical cutting. So active cuts on the apex, which lets you actually redirect or keep placing the implant deeper and deeper. So, that can be, again, a blessing or a curse, depending on what you're doing with it. And N1 does not cut on the apex. So again, I think both work well. I've used them in both for immediate implants, and they both worked quite well. So it's more of a preference of what you want to do. The N1 is going to go where you create the osteotomy. The active will let you have some play to move that position a little bit too. So that's just kind of at least my thought between it. But they look very similar, but there are some noticeable differences.
Yeah. Frank and Brian, one of the things that this patient with the diastema, she wants things closed, and we got to get the infection out, placing the implant. How critical is the timing for implant placement? Because if we have these diastemas, is that 1-2 millimeter diastema in the central, between the two central incisors, one on the distal of the tooth? Is that critical enough or big enough of an issue to have the remaining teeth placed correctly before implant placement? Is there enough correction in our abilities prosthetically, or do you want everything ideal before that implant place? Any thoughts?
Mm-hmm. Well,
that's a tough
all right. Well, here's the way I'm looking at it. To me, it's equal to the topic of immediate load versus delayed load. Okay. It's the same process. You'll get the two camps that have no problem, immediately loading, and the other saying, look, it's not worth the risk. It's under very strict circumstances. And let's just stay traditional. We know whatever the comfort zone is, right? Because it comes down to the practitioner, clinical judgment.
Yep.
Here, I think probably what you're getting around is thinking about, well, this patient's ortho treatment is not going to be 6 months.
No.
Yeah, I think we can agree with that. It typically, I don't know exactly what happened. I know I got blamed for letting the cat out of the bag, but with those. But what stage was she in with the ortho at that point? Since something was bonded on the teeth, what was going on?
She was just in the start of treatment.
So that was the start.
Yeah.
That's the start. And that's her hygiene level too?
Yeah.
At the start? Okay. That's encouraging, huh, Brian? So, all right. So what am I getting at?
Yeah.
If somebody is telling me from the get-go, I don't like my spaces.
Yeah.
Yes.
And I'm guessing, you tell me, how open was she to, for aesthetic reasons, whatever, to a change, some sort of modification of 9? Was she open to it, or just categorically said, no, I have one bad tooth, I want it replaced, leave the rest of my teeth alone, just close the spaces?
She was open to different things. It's just trying to get the right treatment plan for her. And it kind of goes into my next kind of series of questions here, because these are just issues that we see, right? And so how do we manage it?
Well, so I mean, if I'm going to make
it's all about management.
So I mean, if I'm going to make it like the way I would, like we're so retentive, we want it all perfect. I would really want to, yeah, you too included. You're the worst of everybody. But
I thought we were friends, Frank.
Well, listen, I'm keeping it clean right now. Are you kidding? Yeah, when we're off the air, you can actually hear my description, but it's okay. But I mean, if you want the optimal result, the optimal, the teeth are where they need to be, midlines, whatever's going on, dimensions, because you can futz with the mesial distal width of 7, or you can play with 9. Yeah, 9 is almost a little easier depending on where the midline is, but we know a thing about midline. If you cheat a little bit,
you're fine.
But 7 is a bigger thing because that's the lateral incisor. You start making it too wide with somebody who says, I want the space closed, but then next thing you know, space is closed. But how come it's so big compared to the other one? So if they're going to do orthodontic treatment, this tooth has to be gone. Okay, there's no way that I can justify keeping that tooth because number one, what are you going to do with it? I mean, you can't move it. It's already resorbing. You're going to hasten the resorption by putting orthodontic pressures on it. So it's only going to get worse. So the idea is get it out. Well, then, okay, get it out. Well, it's going to be hard to immediately place an implant unless you are so confident that the teeth will move to where you want them to be. Okay. Now that's where I'm confident, but I'm not that daring to take that risk. Okay. Because what's the risk? You take the tooth out, you graft it, right? Because the defect's probably going to be pretty large on this tooth. I'm not even thinking that the teeth are moving enough that I'm going to be worried about any, vacancy of bone, due to a defect, but just you fill up the space.
Yeah.
Well, it's going to take a while for these teeth to move. Is there a risk of some resorption of that graft? Okay, is there? Yeah. I mean, typically, if this patient does what they're supposed to do, it's going to be about 1.5 years. So, I mean, I'll toss this to you guys. I mean, at what point do you start getting concerned with your patients having gone through graft procedures? Now, here we're dealing with a one-tooth space, but we know it. There's other size edentulous spaces, but in a one-tooth space that somebody's gone through some grafting and they're telling you, hey, listen, for my work, I'm getting relocated to Italy for about for some period of time. I'm not sure exactly how long. What would you feel is the timeline that you would like to tell them? Hey, can't you get yourself back to the LA area within this time frame? What works for you so you don't start getting concerned that osseous foundation is getting affected?
Well, I think your comments are excellent, because for me, in a situation like this, I have before where a patient had one little space they were going to move. And so, hey, an implant's put in and we're like, great, this will be fine because we know what we're doing. But then patient relapses and all of a sudden your implant's not in the right spot. So for me, I've become a lot more hesitant to want to put an implant while ortho's planned, because I get nervous about what's going to end up happening. And like you said, whether it's for the bone grafting side or it's just the sake of, hey, that same scenario, they move to another country for a number of months while they're in ortho and they just forget to wear something, and all of a sudden teeth drift, and then you're kind of trying to catch up, but you've got this implant that won't move, and so this becomes your roadblock. So when it comes to the ortho side, I feel a lot safer. Get everything moved to where you want it, then put the implant in, because you never know what's going to happen with either patient compliance or what, all of a sudden patients like, I just want to close this diastema. But then once they consult with the orthodontist, all of a sudden it becomes a full mouth, maxilla and mandible. You're in, ortho for 2 years or whatever, 3 years, whatever, however long it might take. I don't know. But, I think that's where I'd get nervous, because now you got this implant that you're basically on hold with until the ortho's done. So I feel a lot safer waiting until ortho's done. I think it's a lot more predictable for more people. Yeah.
Agreed. Brian, there's a couple questions here regarding the N1. One question from Dr. Peter. With the N1, does the abutment seat similar to a Morse taper? Do you get a cold well? Can we make custom abutments? Any limitations with the restorative cases or patients?
Yeah, I mean, that can be a loaded question, because that's a lot of topics. But for sure, the connection itself goes definitely a lot tighter. So you're going to not technically cold weld, but you're getting a lot closer. You go to an 8 degree. From 12 degrees is what conical connection has to 8 degrees. And so you're not technically getting cold weld, but give you an idea, there is an instrument that we have to help us remove the abutment. And so, there is obviously, it can be a little more challenging to remove, but I've yet to have an issue. I had to take a component out on Monday, and I had to use the abutment removal tool, and it worked great. So it wasn't something that, I don't normally remove anything, but yes, it is a good connection in terms of the tightness. It's also twice as long as conical connection. So you've got a good seal, and again, a good transfer of force into, from the component. And again, as it fits nicely into the implant, which is great. So no question there, but yeah. But
there's another question.
Please.
Another question also for you. the new design of the N1 worked out with Dr. Helms and input. Can you comment if you have any concerns using a smaller OmniGrip screw that uses less torque than the original OmniGrip ASC screw?
Sure.
That was from
at the
Dr.
end of the
Macy.
day, oh, cool. I mean, at the end of the day, in all honesty, when we talk about torque values, I mean, it's always a fun conversation. I love to have that conversation with engineers because it is kind of a fun discussion when they look at it from even other industries. But 35 Newton centimeters that we use on a daily basis, that was something that was determined by the engineering side based on the size of a screw early on. And so that kind of became our standard to say, okay, well, we want insertion torque of an implant, for example, to be 35 Newton centimeters or more so that we can torque a component if we're doing something immediately, as an example, at least. And so the whole purpose of a screw is to just hold two components together. And so really the screw is primarily just to pull the components together with the internal conical connection as an example. You're just pulling the components together. And then from that point, it's the connection that's holding all those forces. So I don't get as worried about 35 Newton centimeters versus 20 Newton centimeters personally. And I haven't had any issues yet. Again, I've only been placing the implants for about a year and a half or restoring them. So, that kind of, again, for me, I haven't had any issues. You do have to adjust occlusion, right? And all those principles we follow because you can overload anything. But I'm not worried about a difference in torque value for me, at least.
So the question comes up next is about this case, and they want to know: are we going to tell you what have we done?
What was done?
Are you going to eventually tell us what does it look like? To be quite honest,
No.
We're still going through the consultation. No, we're not.
Keep you guessing.
Actually, I kind of was a little selfish. I brought it up to you guys so I can figure out what to do with this patient.
Yeah, I'm telling you, this is why it's called clinical chat.
It's awesome. It's awesome.
So, the doctor that asked, what are we doing? We're just going through the consultations, getting the consults with all the orthodontists, the periodontist, and everyone else, and trying to how we move forward with this for her. So thank you for that response. I can't believe how much time has gone by. This has been a great chat. Great coming back from our hiatus here. As we move along here, one last quick question, Brian, before we finish up, because we only have a couple minutes. Are the abutments less likely to loosen with the N1?
Yeah, I mean, it's twice as deep into the connection. So I think that's something that is, I feel yes, because you're not going to have it loosen. You have to, again, when you have the tighter, taper as well as a deeper connection, I mean, just, biomechanically, that's going to be harder to loosen.
Perfect. Well, I want to thank you two, my two dear friends, Dr. Brian Goodacre, Dr. Frank Vidjak. It's an honor and privilege to have had you both on the show. In fact, if I can let the cat out of the bag, Brian, Brian has agreed to join Frank and I on a more semi-permanent basis. Depending on his travel and whether, you can see that he's in Oklahoma and it's on the program here with us. It just depends on his traveling and where he's at. Brian, we welcome you. Thank you for joining us. We love having you. This is a great chat. Just the three of us talking. It's just like sitting over dinner and just talking about things. And that's what's fun. And
I want the dinner. So where's the wine? That's what I want. Virtual wine from the Marchack cellar.
Water.
It's a special software. It gets rid of the color where you want it. That's what it is.
So thank you, Brian. Thank you for being more on a kind of a permanent basis with us. Our next episode of Clinical Chats will be on Wednesday, October 11th. And we will continue the schedule of being on the second Wednesday of the month at 5 p.m. Pacific time. So watch out for our mailers and the topics of the discussions. Our next topic will be, is this possible? A fractured zirconia implant prosthesis? Can it happen? Boy, that opens up a whole big can of worms. So watch out for the mailers, October 11th, 5 p.m. With my utmost enthusiasm, I would like to extend my heartfelt gratitude to all of you, our beloved fans, our viewers, to creating brilliant smiles that make the world a brighter place. Stay well, my friends, and until we meet again, take care, Brian. Take care, Frank. Great to have you.
Thank you. Good to
Bye.
see both of you.
It's always
Take
fun.
care, everyone.